Shall we start?
Yeah, please.
A very good evening to one and all present here. It's my immense pleasure to welcome everyone to ISA National PG class. I am Dr. Gauri Nair, anesthesiologist from Trivandrum. ISA National PG class is a very useful aid for all the PG students. It is conducted every week with very interesting topics. Today's topic is anesthesia for appendicectomy in a pregnant patient. The physiological changes of pregnancy with the safety concern for the fetus as well as the mother will determine the type of anesthetic technique, drugs, and monitoring. All this will be discussed in today's class. Let's start today's evening by paying respect to Goddess Saraswati by playing Saraswati Vandana. Now, I would like to welcome Honorary Secretary of ISA National, Dr. Sukhminder Jit Singh Pajwa sir, to say a few words.
Thank you, Dr. Gauri. Uh, the topic actually is this appendicectomy and that too in a pregnant patient. I think again we are going back to the basics of our PG curriculum where we always say the non-obstetric surgery in obstetric patients. And this is, I think, one of the most practical, most common things we are facing when we pass out from the college during period also, but that time we are under supervision. The decision making is very difficult when you pass out and you are encountering as an independent practitioner or as a consultant in some hospital where you are a one-man army. Very difficult for them actually. The decision to go for the spinal or for the GA. There are so many other factors I think which have to be taken care of, and especially you are dealing with the two lives. One is such a small life that how much anesthesia can be titrated, which drugs to be given, so many uteroplacental transfusion dynamics, and again the hemodynamics, then temperature monitoring, and so many things are there. It's not an easy task that going for any surgery in obstetric patient is that easy that you give spinal, the surgery is over. In these type of patient, the perioperative monitoring is the gold standard. Every minute, every second minute, every third minute is important because any deviation or any what you call dropout of more than 20-30% in the hemodynamics or in the whatever other respiratory dynamics or other things, I think that's going to disturb the internal milieu of the pregnant patient, and that will be a catastrophe post-operatively. The challenges are numerous. I think with advanced medicine, we are getting more into this picture. Now we may be doing the exit procedures during these things, during this type of advancement, which has given us the scope for going for those procedures. But still in India, in a developing nation, especially in the peripheries where you are encountering so many pregnant patients coming for a non-obstetric surgery, I think that's a very, very important topic to be discussed. And we have got a very good team. and they will be presenting this topic today, and they must have prepared very well. I am fully confident of Dr. Imran, Dr. Nanda Madam, and Dr. Rupa. They must have prepared their PGs very well. So I think we should start the class. Dr. Gauri, back to you.
Thank you, sir. I now invite my co-screen coordinator, Dr. Ankita Saini, to kindly introduce the esteemed faculty moderators and also to outline the rules of the session and the session format.
Thank you, Dr. Gauri. A very good evening to all. I am Dr. Ankita. I am working as a senior resident in Dr. B.L. Kapoor Max Hospital, Delhi. So it's an esteemed honor to be serve as a screen coordinator for today's session for ISA National PG online class. So our first faculty of the day. First faculty of the day is Dr. Mohammad Yaha. He is the professor and head of department of MR Medical College, Kalaburagi, Karnataka. Sir have more than 17 years of PG teaching experience. He is specialist in regional blocks. Sir has been organizing chairman, Souvenir Committee, ISA Con Karnataka 2022. He has been a member of Ethical Committee, KBNU FOMS Kalaburagi. Sir has authored 20 publications in international and national journals. I welcome you, sir, and we are honored to have you with us today. Our next distinguished faculty for the day is Dr. Nanda S. Nandyal. Ma'am is a professor in Department of Anesthesiology in MR Medical College, Kalaburagi.
Excuse me, Dr. Ankita, just wait. The CV screen is not visible.
Okay,
Dr.
okay.
Gauri,
Yes, ma'am.
can you please widen the screen?
Yes, ma'am.
Widen the. Yes, please go on, Dr. Ankita.
Ma'am, should I start from Dr. Mohammed?
No, you carry on with the ma'am. Dr. Mohammed, we have heard. Is
Okay, sir. Our next faculty is Dr. Nanda S. Nandyal. Ma'am is professor and in Department of Anesthesia in MR Medical College, Kalaburagi, with an impressive 19 years of postgraduate teaching experience. Ma'am have areas of interest including regional and obstetric anesthesia. She has been an active academic and leader, serving as organizing chairperson for the Food and Banquet Committee at ISA Con Karnataka 2022, and also chairperson for the case presentation at ISA PG Excel Maharashtra chapter, and judge for multiple PG paper and poster presentations at various conferences. She has 14 publications to her credit in both national and international journals. We extend a very warm welcome to you, ma'am. Our third faculty of the day is Dr. Rupa Holkonde. She is an assistant professor in Department of Anesthesiology, MR Medical College, Kalaburagi. Dr. Rupa ma'am has 9 years of
Just Dr.
postgraduate.
Ankita, just can you change the slide?
Yes.
Okay, go ahead.
Yes.
No, the
Dr.
slides are
Rupa
not seen. The slides are not seen. Yeah. Yes, please go ahead.
Is it? Yes.
Please
Dr.
go ahead.
Rupa, yes. Dr. Rupa Halkande, she is Assistant Professor, Department of Anesthesiology, MR Medical College, Kalaburagi. She has 9 years of postgraduate teaching experience with special interest in regional anesthesia and pain management. She holds a fellowship in basic regional anesthesia and pain management from the prestigious Daradia Institute of Pain Management, and she has been invited as faculty speaker at State ISACon Conference 2024. She has also contributed to academics with 4 publications in narration in national and international journals. We are delighted to have you, ma'am, today. With all being said, before commencing the session, I would like to enumerate the rules for the audience for the today's class. So, I would request all to switch off your videos. Also, you all be muted throughout the session. And please write down your queries in the chat box. We will be taking all the queries at the end of the session. Thank you. And before starting the session, I would request the faculty to introduce the PG students who are going to present today's class.
Ma'am, please unmute yourself. Yeah.
With warm greetings from Mahadevappa Rampuri Medical College and Basaveshwar Teaching Hospital, Kalburgi, Karnataka. I, Dr. Nanda Nandyal, Professor, Department of Anesthesiology, wants to thank to whole of the team of ISA National PG classes. Especially thanks to Vajba sir and Madhuri madam and her team. I welcome my postgraduates, final year students, Dr. Vijayasri and Dr. Stuti, for presenting a case of anesthesia for appendectomy in pregnancy. And we will start the session.
Stuti, share the PPT.
See the PPT?
Yeah. Start sharing your PPT from the beginning.
Yeah, that is
Okay.
That's okay. Make it widescreen.
Now, ma'am, now
No,
can you see the PPT?
we can see only, we cannot see it.
Slide, press slideshow. Just above now, near the insert.
Now, ma'am,
No, now
Yes. Don't
It's
keep
there?
moving. Now go slowly to the next slide.
yes, ma'am.
Move to the next slide.
Now it's there?
Yes, stop there. Yeah.
Yes.
You can start, ma'am.
press the green button. It's again.
Uh,
No, it's
It's going in 2 slides, so kindly adjust that sharing.
Now.
Slide
Now-
share. No, not it. Yeah.
now press the green button. That green.
Now, ma'am. Now can you
Yes.
see?
Yes.
Yeah.
Now,
Okay.
Start.
Yes.
Yes.
Good evening, everyone. Myself, Dr. Dynamis Stuti, postgraduate, Department of Anesthesiology, MR Medical College, Kalburgi. I will be presenting a case on appendectomy in pregnancy.
Myself, Dr. Sai Vijayashree, postgraduate, Department of Anesthesiology, MR Medical College, Kalaburgi.
Press the green buttons.
Yes.
Make it full screen.
Yes, ma'am.
Ma'am, now can you see?
No.
No,
Is it
not.
seen, ma'am?
Yes, yes.
Now, ma'am, is it seen?
Yes.
Is it seen, ma'am?
Yeah.
yeah, it's
Our
visible.
patient is a 27. Yes, ma'am. Our patient is a 27-year-old female, Mrs. Anjana Mahesh, resident of Kalburgi, homemaker by occupation, belongs to middle class of socioeconomic status. She was admitted on 27th of September and was examined on the same. She presented with complaints of pain abdomen since 3 days, vomiting since 1 day, 3 to 4 episodes, fever since 1 day, and she gives history of 6 months of amenorrhea. Patient presented with complaints of pain around the abdomen, pain abdomen since 3 days, began around the umbilical region, gradually migrated to the right lower abdomen. First, the pain was diffuse, dull, and intermittent, which gradually progressed to sharp and continuous in nature, not associated with contractions, tightening of abdomen, no aggravating or relieving factors. She also complained of vomiting since 1 day, 3 to 4 episodes, non-bilious, non-projectile in nature, with fever since 1 day, low grade, gradual in onset, intermittent, not associated with chills or rigor. No complaints of burning micturition, increased frequency of micturition or hematuria, vaginal bleeding or discharge, upper abdominal pain or heartburn, altered bowel habits, constipation or diarrhea, yellowish discoloration of eyes or dark colored urine, no history of abdominal trauma, no significant comorbidities or history of previous surgeries, transfusions, allergies. She is a primigravida with spontaneous consumption. She had mild history of nausea, vomiting in the first trimester with folic acid supplements taken. She perceived quickening at 5 months of amenorrhea, injection TT, iron, folic acid, and calcium supplements were taken. Menstrual history, normal. Family history, no significant family history. Personal history was normal.
What are the causes of abdominal pain during pregnancy? Obstetric and non-obstetric
Ma'am,
causes.
Abdominal pain in pregnancy can be divided by trimester wise. In the first trimester, the obstetric causes are the threatened abortion, ectopic pregnancy, molar pregnancy, and corpus luteum cyst rupture. The non-obstetric causes are appendicitis, gastroenteritis, urinary tract infection, and ovarian cyst torsion. In the second trimester, there is placental obstetric causes are placental abruption, preterm labor, and round ligament pain. Non-obstetric causes are appendicitis, cholecystitis, pancreatitis, bowel obstruction, and urinary tract infection. In the third trimester, the obstetric causes are preterm labor, placental abruption, labor pain, and uterine rupture, which is rare. Non-obstetric causes are similar to that of the second trimester.
According to the history of your patient, your likely probable cause for this abdominal pain is whether it is obstetric or non-obstetric.
Ma'am, according to the history, it seems to be non-obstetric cause because we have ruled out by asking history of pervaginal bleeding, any history of micturition symptoms. So we suggest that it is a non-obstetric cause of pain abdomen.
Next.
On general physical examination, patient was conscious, well-oriented to time, place, and person, moderately built and nourished, hair normal. From head to toe examination, hair normal, all other head to toe examination was normal with no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. She weighs around 68 kg, height 158 centimeters, BMI of 27.2 kg per meter square. All the vital signs were examined, were within normal limits. Spine examination was normal. Airway examination, mouth opening adequate, 3-finger mouth opening, modified Mallampati grade 2, dentition, thyromental distance, sternomental distance, and neck movements were normal. On systemic examination, per abdomen showed us on inspection, shape of the abdomen globular, symmetrically enlarged with umbilicus center and diverted, linea nigra was present, no engorged veins or pulsations. On palpation, all the inspectory findings were confirmed, uterus 24 weeks relaxed, tenderness present in the right iliac fossa, rebound tenderness was present, Rosewing sign and psoas sign was negative, no local rise of temperature, spleen and liver not palpable. On auscultation, fetal heart sounds were perceived, 140 beats.
What is Rosewing sign and psoas sign?
Ma'am, Rosewing sign is when we palpate the left lower quadrant of the abdomen, the patient perceives pain in the right lower quadrant of the abdomen. This is due to the tenderness is due to the spreading peritonitis due to a perforated appendix, which is not present here. And psoas test or psoas sign is when the patient's right hip is hyperextended and patient perceives pain in the right lower quadrant. This is due to the retrocecal appendix, which lies on the psoas muscle. When it is stretched, it causes pain, which is also negative, suggesting no retrocecal appendix on examination.
Okay, next.
Respiratory system, cardiovascular system, and central nervous system, no abnormality was detected. Our provisional diagnosis is a 27-year-old female, primigravida with 26 weeks plus 1 day gestational age with pain abdomen.
How will you confirm the diagnosis?
Ma'am, the confirmation of diagnosis, I prefer going with ultrasound abdomen and pelvis, as it is safe in pregnancy, and also it will be able to differentiate between the obstetric, whether it is obstetric or non-obstetric cause, and also assess the fetal well-being. And if the USG is inconclusive, I go with MRI as it is safe in pregnancy, and also there will be we can go with the MRI as it is safer, and there'll be a more of tissue visualization is clear in MRI.
Why not CT scan?
Ma'am, CT scan as a radiation exposure is more, which is around 25 to 50 milligray, which is harmful in pregnancy, where the limit is less than 50 milligray.
How much of the radiation exposure is allowed during pregnancy?
Ma'am, it is less than 50 milligram.
Coming over to the first MCQ of our day. So for the audience, by the third trimester of pregnancy, cardiac output increases to nearly 50%, due to which of the following alterations? Your options are: option A, decrease in stroke volume and increase in heart rate; option B, increase in stroke volume and decrease in heart rate; option C, decrease in stroke volume and decrease in heart rate; or option D, increase in stroke volume and increase in heart rate. We'll give you 30 seconds to type your answer in the chat box. I'm seeing good response. Thank you, everyone. We'll discuss the answers at the end of our case presentation.
No, I think you can just
Yes,
Proceed.
you can finish it off. Yeah. Just wait for
Yes,
the
ma'am.
answers
Okay.
and then finish it off.
Next.
Dr.
Yes,
This
okay,
one,
next.
Dr. Gauri, just keep on seeing who has given what answers.
Next.
So next, going to the next.
Now you have come to provisional diagnosis, and also you have confirmed the diagnosis on ultrasound. Now you have to manage the case. As she is a pregnant patient, you should know, before managing the case, you should know what are the normal anatomical and physiological changes during pregnancy. In brief, you describe about the anatomical and physiological changes during pregnancy in each trimester.
No. First, we'll see the cardiovascular changes. In cardiovascular changes, the heart is enlarged due to the increase in the blood volume because of the vent, and it causes ventricular stretch. And on examination, there will be loud S1, also the physiological ejection systolic murmur. And in ECG changes, there will be non-STT changes, which is normal, and there is left axis deviation due to the push of the diaphragm by the uterus, and there is a shortening of the PR and QT interval. Then cardiac output is increased by 30 to 50%. This is because of the increase in the heart rate and the stroke volume. Systemic vascular resistance and the peripheral vascular resistance is decreased because of the vasodilatory effect of the progesterones, causing decrease in the blood pressure less by 22 to the 35%. And because of there is at the after 20 weeks of gestational age, there is we can see supine hypertension syndrome, where because the uterus compresses the inferior vena cava, causing the decrease in the venous return and lessens the cardiac output. So there will be a decrease in the systolic pressure of 20 mmHg and diastolic pressure of 10 mmHg. And IVC compression, there is epidural venous engorgement, reducing the epidural space. So we need to reduce the dose of the local anesthetics while giving regional anesthesia. Respiratory and airway changes. In the respiratory system, the alveolar ventilation is increased by 30%. This is due to the progesterone effect on the respiratory system, causing mild respiratory alkalosis, and there is compensatory bicarbonate decrease. There is increase in the oxygen consumption by 20 to 30%. This is to meet the metabolic demands of the mother and the fetus, and the functional residual capacity is decreased by 20%. This is because of the upward displacement of the diaphragm and the increase in the intra-abdominal pressures. So this reduces the oxygen reserve and leading to hypoxemia, and also the reduces the apnea period of time during the induction. And because of as there is progesterone effect, so there will be mucosal edema, friability, and breast enlargement and weight gain. These all lead to difficult airway, and we have to avoid multiple attempts during intubation. Hematological changes, the plasma volume increases by, blood volume increases by 30 to 45%, where the plasma volume is more than the RBC cell mass, leading to physiological changes in anemia. And the WBC count is increased, and the blood viscosity is decreased, and the platelet, there is a slight decrease in the platelet count. Coagulation profile, there is increase in the fibrinogen and the clotting factors 7, 8, 9, 11 and 12, and this leads to hypercoagulable state. This increase is due to mainly because to compensate the blood loss during the delivery, and the side effect is there is risk of thromboembolism.
This changes in the central nervous system, as we see, are there will be
add a
reduction
note on oxygen dissociation. Vijayashree, add a note on oxygen dissociation curve during pregnancy, and it's
during
important.
pregnancy, the oxygen dissociation curve shifts to the right, and because as there is affinity of the hemoglobin reduces, and in the fetal circulation, the fetal hemoglobin has more affinity for the oxygenation, so there will be a shift of the curve to the right, and there will be Bohr effect.
So due to increase in 2,3 DPG level, there will be shifting of oxygen dissociation curve in the mother to the right for easy delivery of the oxygen to the placenta. And in fetus, because fetal hemoglobin has got high affinity to the oxygen, so the shift of the curve is towards the left, which will increase, reduces the delivery and increases the oxygen concentration in the fetus. It is for proper oxygenation of the fetus from the maternal circulation. Next.
Physiological changes in central nervous system. The minimum alveolar concentration of inhalational and anesthetic drugs will reduce by 25 to 40%. This is due to increased secretion of progesterone and endorphins, and also due to increased minute ventilation. Hence, the requirement of dosage of inhalational anesthetics will be reduced. Pseudocholinesterase level, it is said that it is reduced by 25%, but there is no change in the succinylcholine dose or the effect, because there is increased volume of distribution. Protein binding is reduced because of decreased albumin levels. Hence, free fraction of drugs is increased. It is also said that cerebral blood flow is increased. In the first trimester, it is 44 ml per minute per 100 gram of brain tissue, and by term, it increases till 51 to 55 ml per minute per 100 gram of brain tissue. Also, it is also said that in musculoskeletal system, because we have seen that there is epidural venous engorgement, there will be decrease in the space in the subarachnoid space and the epidural space. Hence, the dosage of local anesthetics that we give has to be reduced. And also, due to increased lumbar lordosis, there is also reduction of dosage. And also in pregnancy, there is increased sensitivity to local anesthetics. That's also the reason why we have to reduce our local anesthetic dosages. Now, in gastrointestinal system, majority or the main important change that occurs is lower esophageal sphincter tone is reduced. This happens as the gravid uterus pushes up. The stomach is shifted towards 40 degree and also pushed towards the left dome of the diaphragm. And also due to increased progesterone secretion, it causes the relaxation of the lower esophageal sphincter tone. This is of important significance as there is aspiration chances or risk in pregnant females, pregnant mothers. Also in pregnancy, there is no effect over the gastric emptying as such, but every pregnant mother has to be considered as full stomach. There is increased gastrin secretion in the stomach, hence there will be chances of acid aspiration. And due to the increased pressure increased pressure due to gravid uterus, there will be increased intragastric pressure, causing any full stomach patient, or if patient is not NBM, rapid chances of aspiration. Renal system physiological changes that occurs are renal blood flow increases by 50 to 75%. In first trimester, it is by 75%, and by the term, it comes to 50%. This is due to vasodilation, and it helps in increased clearance of renal excreted drugs. Also, GFR rate increases by 40 to 50%. Creatinine clearance also, in normally it is 100 ml per minute, but it is increased by 150 to 200 ml per minute. Therefore, there is clearance of renally excreted drugs. Sodium and water retention occurs in pregnancy. This is due to RAS activation. There is increased intravascular volume.
Coming over to the next MCQ, based on the physiological changes that you people must have heard till now. During pregnancy, the disproportionate increase in plasma volume versus erythrocyte volume accounts for, your options are increase in mean arterial pressure, increase in stroke volume, increase in cardiac output, or relative anemia of pregnancy. Okay, we'll continue
Continue with
proceed
the
with the
case
case discussion.
Which trimester is safe for the surgery?
So
You want to
for
summarize it?
Uh,
You summarize this.
summarize the physiological changes of all the systems together.
To summarize all the physiological changes that we have learned till now, in cardiovascular system, we see that the cardiac output is increased by 30 to 50% with an increase in heart rate, with an increase in blood volume. And we also see in respiratory system, there is increase in tidal volume, increase in minute ventilation, FRC is reduced, oxygen consumption is increased. Gastrointestinal system, there is lowering of the lower esophageal sphincter tone, and there is increased intragastric pressure, delayed gastric emptying, increased aspiration risk. In hematology, we have seen there is increased plasma volume. There is increased plasma volume more than the RBC mass, hence there is physiologic anemia, and it is a hypercoagulable state. In renal system, we have seen there is increased GFR, increased renal blood flow, increased creatinine clearance. In airway, we have seen that there is mucosal edema, diaphragmatic elevation, and it can impose to difficult airway and positioning.
So again, related to the physiology, what is the P50 for maternal hemoglobin? It increases due to elevated levels of 2,3-diphosphoglycerate. It remains unchanged, or it increases to maintain the pH, or it decreases to enhance the oxygen delivery to the tissues. So everyone can type their answers in the chat box. We'll go ahead with.
Now we are clear with all the changes, anatomical and physiological. Add a note on pharmacokinetics in pregnancy of drugs.
Pregnancy alters all the four aspects of the pharmacokinetics. So there is delayed gastric emptying and increased gastric pH, leading to slower and sometimes reduce of the oral absorption of the drugs. And the plasma volume and the body fat increases. So because of this, there is increase in the volume distribution, and there is also decrease in the protein binding. So the drugs we have to taper and give the drugs. Hepatic enzyme activity is enhanced, so causing the faster metabolism of many drugs. Renal blood flow and glomerular filtration rate is increased, increasing the creatinine clearance. So overall, many drugs require dose adjustment and increased this is due to the increased distribution of volume and faster elimination in the pregnancy.
So, what trimester is safest for surgery? As you have just now seen the physiology and the pharmacokinetic changes. So, what trimester is considered as safe for the surgeries, and why?
Second trimester is considered safer for the non-obstetric surgeries, ma'am. This is because by this trimester, the organogenesis is complete. The organogenesis happens in the first trimester. There can be, during that trimester, if there are surgeries, if there is any exposure to anesthetic drugs, there is risk for teratogenicity of the fetus. But in second trimester, it is safe as there is lesser risk of teratogenicity compared to the first trimester. And the second important factor is uterus size is moderate. It is not so enlarged, so there is easier surgical access and lesser aortocaval compression when compared to term. And also there is lower risk of preterm labor when compared to the third trimester.
How will you decide the timing of the surgery?
And if time permits, you can defer the surgery to second trimester. How will you decide that?
Ma'am, as as we have seen that it's an appendicectomy surgery, we would like to go ahead and ask for the history and speak to the surgeon whether it is perforated or not, to find out whether it is emergency, urgency, or elective surgery. So these three categories come based on the life-threatening situation to the mother or the fetus. So in emergency surgeries, it is life-threatening to the mother and the fetus. They both are at risk. The main important example is perforated appendix, maternal sepsis, sepsis and uncontrolled bleeding. In urgency, it is within 6 to 48 hours, it has to be operated. This can be that there is risk present to the mother or fetus, but not immediate. You can optimize and then take them for surgery. This can be non-perforated appendix and symptomatic cholelithiasis. Elective surgeries are when surgery can be safely postponed to the second trimester or even postpartum period, where there are minor surgeries like hernia repair or any gallstones without any symptoms.
Now you have decided this is an emergency case only, and you have to give anesthesia to this case. How will you proceed for the investigations?
Oh, ma'am, I'll advise basic preoperative investigations, that is complete hemogram, renal and liver function test, blood grouping and cross-matching, urine routine and coagulation profile. For my case, I go with the ECG as it is both the baseline, I'll have a baseline documentation and also to rule out the pregnancy-related cardiac changes and underlying cardiac diseases. I also go with
hemoglobin during pregnancy.
Hemoglobin
criteria you follow while like labeling the patient as anemic or non-anemic or normal hemoglobin? Hemoglobin levels in different trimesters?
In the first trimester, the hemoglobin level will be around 11 to 12 gram per dl, and which is considered normal. And in the second trimester, it is around 10.5 to 11, and in the third trimester, 10 to 11 is considered normal. Total count, WBC count, in the first trimester, it is 6,000 to 12,000 is considered normal. In second trimester, from 6,000 to 13,000 is considered normal, and in the third trimester, from 6,000 to 15,000 is considered normal. And platelet of around
indicator for indicating the underlying infection. And what about platelet count?
Platelet count of around 1.3 lakh to 1,50,000 is considered normal in pregnancy. And I go with zero.
What are the normal urea and creatinine level, as they are same with the normal non-pregnant during pregnancy?
No, during pregnancy, during pregnancy, the urea levels will be considered normal because it is 25 mg per deciliter, ma'am, and even creatinine 0.4 to 0.6 mg per deciliter is considered normal.
Next.
So our final diagnosis, she is a 27-year-old female, primi gravida with 26 weeks plus 1 day gestational age with acute appendicitis, posted for laparoscopic appendectomy.
So how will you counsel the patient and relatives regarding the maternal and fetus risk?
Oh, ma'am,
Now
I'll
she
proceed with
for the surgery.
I'll proceed with the multidisciplinary approach involving obstetrician, surgeon, and the neonatologist. And I'll counsel the patient and attenders about the maternal and the fetal risk, and also the postoperative monitoring, and the fetal risk like preterm labor and fetal distress is explained, and also intraoperative cesarean section, and reassure about the safety of the anesthesia. And I also take that in detailed informed and written consent from the attenders and the patient.
How will you pre-optimization of the patient you will do?
As we have taken history, patient has come with complaints of pain, abdomen, vomiting, and fever. So we would like to maintain hydration. We would like to give crystalloids to the patient and maintain hydration. And antipyretics, injection paracetamol, 1 gram IV every 6th hourly can be given. Antiemetics, injection ondansetron, 4 mg IV can be given. Antibiotics, the first line of drugs in pregnancy would be cephalosporins, as we will have to avoid tetracyclines, aminoglycosides, which can be teratogenic. NBM, as per ASA guidelines, has to be maintained. Heavy meal for fried, fatty, or meat, it has to be 8 hours. For solids with light meal, it has to be 6 hours. For clear liquids, it has to be 2 hours. Aspiration prophylaxis will
be aspiration prophylaxis.
Yes, ma'am. As we have seen, most of the as we have seen in pregnancy, the lower esophageal sphincter tone is lost. There can be high risks of aspiration in pregnancy. So aspiration prophylaxis has to be done for every patient coming posted for surgery. So the 4 classes of drugs will be non-particulate antacid, sodium citrate, 30 ml should be given per orally, which is 0.3 molar. 30 minutes before the surgery. It helps in neutralizing the gastric acid that is secreted. It is safe and rapid in action. H2 blockers, that is injection ranitidine 50 mg IV to be given. It helps in decreasing the gastric acid secretion. And prokinetics injection metoclopramide will 10 mg IV to be given 30 minutes before induction. It helps in gastric emptying of all the contents of the stomach. And the proton pump inhibitors injection pantoprazole 40 mg IV to be given 30 minutes before surgery. It helps in reducing the gastric acid secretion.
Now your surgeon wants to do this case under laparoscopy, but before that you should know what are the merits and demerits of over laparoscopy and laparotomy among the two.
Laparoscopy versus laparotomy. We have seen that this patient is posted for laparoscopy. In laparoscopy, the main advantages that we see will be smaller incisions, lesser pain and faster recovery. And there will be visualization of the appendix and abdominal organs, lesser wound infection rate. But there will be disadvantages with laparoscopy. That is, as we know that they will insufflate the abdomen to create pneumoperitoneum with carbon dioxide. It can cause carbon dioxide absorption. It can cause chances of carbon dioxide absorption leading to acidosis in the mother and the fetus. It can also cause injury to the uterus by trocar injury. It can also cause it can also be technically challenging in later trimester because the uterus is enlarged. Now, in laparotomy surgeries, it is direct access to the appendix. The surgeon directly visualizes the organ, and there is no need of CO2 insufflation and no need of any specialized positioning. The disadvantages will be larger incision, more post-operative pain. There will be slower recovery, longer hospital stay, and higher risk of wound infection. In laparotomy surgeries, one of the main drawback is there can be increased risk for preterm labor if there is uterine manipulation which is done intra-op.
Now coming over to as you have decided the laparoscopic benefits, considering the benefits of laparoscopy over laparotomy. So laparoscopy is finalized. So what will be your choice of anesthesia?
Since we are going ahead with laparoscopic appendicectomy, our plan for anesthesia will be general anesthesia with endotracheal tube intubation. This is because in endotracheal intubation, the advantages will over regional anesthesia will be controlled ventilation will be there. We can monitor the EtCO2 levels, and also this is and also we can maintain normotension in general anesthesia, but it also has its own disadvantages. That is, the anesthetic drugs that we use, there can be increased transplacental transfer. If there is difficult airway, there can be difficulty in securing the airway. And since we know that regional anesthesia provides excellent post-operative pain for at least 4 to 6 hours, but in general anesthesia we will have to use systemic analgesics. And also in regional anesthesia, there is higher risk of aspiration when compared to regional in regional anesthesia, and also fetal depression is possible more in general anesthesia when compared to regional anesthesia.
So what are your intraoperative goals and how do you proceed with the management of the case?
The anesthetic goals will be maintaining the maternal and the fetal oxygenation and avoiding hypotension and prevent hypoxia and hypercapnia. And there will also have to minimize the arteriocaval compression by giving 50 degree of left tilt, and I'll use safer anesthetic agents and ensuring covering the aspiration prophylaxis, providing smooth induction and recovery without uterine stimulation, and also monitoring the fetal heart rate. Here we go with some pharmacological and non-pharmacological effects that are physiological changes affecting the maternal and the fetus. Non-pharmacological effects, because of as there is arteriocaval compression which reduces the blood pressure, decreasing the venous return and causing maternal hypotension, indirectly causing uteroplacental perfusion reduction. There will be fetal hypoxia and acidosis. And due to difficult airway or during the apnea period, there can be a hypoxia which leads to maternal desaturation, and which affects the fetus, causing fetal hypoxemia and bradycardia. And if there is any hyperventilation, it leads to respiratory alkalosis and leads to uterine vasoconstriction and decreasing the placental blood flow. And We have to avoid hypothermia as it causes peripheral vasoconstriction in the mother, and this decreases the uterine blood flow to the fetus and causing fetal hypoxemia. And supine position should be given as this decreases the iotocaval compression and preventing the venous return and hypotension. And if not, there will be the fetal distress and the decreased placental perfusion. The pharmacological effects over the mother and the fetus has to be kept in mind. Volatile agents that we use, they cause decrease in the tone. They cause uterine relaxation, decrease in the tone, which reduces the uteroplacental perfusion, can lead to fetal hypoxia. IV induction agents that we use, they cause sedation in the mother, and they can cause fetal respiratory depression because of the fetoplacental transfer that occurs. Opioids causes respiratory depression in the mother and the fetus, has to be carefully used. Benzodiazepines, few of them can cause neonatal hypotonia, floppy infant syndrome, and sedation in the fetus. Local anesthetics, lidocaine is more preferred than bupivacaine. It can also cause fetal CNS and cardiac toxicity, but in rarer conditions. Muscle relaxants, succinylcholine, rocuronium are considered safe. They have minimal fetal effect. The vasopressors, phenylephrine is preferred over ephedrine, and also vasopressors are used to maintain the uteroplacental perfusion. Before we go ahead with using the anesthetic drugs, we will always have to keep in mind the feto-maternal ratio, because the fetoplacental transfer of drugs that we use are very important. The fetoplacental transfer of drugs occurs because of certain factors, that is the molecular weight of the drug, that is the pH of the drug, ionized state of the drug, and whether it is lipophilic or not, and also because of also because of the pKa of each drug. So certain drugs that we use and their fetomaternal ratios are considered here. If the fetomaternal ratio is closing or nearby 1, which means it rapidly transfers across the placenta, and it can cause fetal effects. Glycopyrrolate fetomaternal ratio is around approximately 0.01. Atropine is 1:1. Midazolam is 0.7. Diazepam is 1 to 1.5, which rapidly crosses the placenta. Propofol is 0.6 to 0.8. Ketamine is more than 1. Thiopentone is 0.6 to 1. Fentanyl is 0.3 to 0.5. Succinylcholine is minimal, that is 0.01. Rocuronium 0.16. Vecuronium 0.06, and nitrous oxide 0.8.
Now coming over to our next MCQ. When providing general anesthesia during pregnancy, the MAC is option A increased, option B decreased, option C unchanged, or option D it is unclear.
Next, Stuti, you have to keep in mind some factors affecting the uteroplacental circulation also while managing this case. So what are the factors which will affect the feto-maternal circulation or fetoplacental circulation? Maternal
Ma'am, voice is cracking. Hello? Ma'am, voice is cracking, ma'am. Hello?
What are the factors affecting feto-maternal circulation?
Ma'am, may I request that we keep the MCQs for a little more time? We are not able to see the MCQ properly, last one.
Okay. Ma'am, the factors
we can
that
just stay here for 10-15 seconds and then we can move ahead.
Okay.
And I request the audience to answer these questions, because right or wrong, if you answer these questions, you will remember it for the rest of your life. So please answer the questions, and we can discuss this later on as per the faculty's convenience.
At the end, the MCQs.
Okay. Ma'am, the factors that affect the fetoplacental circulation, there are mainly maternal factors, fetal factors, and the placental factors. Maternal factors, as we know, it is the maternal BP, maternal blood pressure, maternal mean arterial pressure, and the heart rate. In fetal factors, it will be the heart rate, the umbilical artery blood pressure, and the blood volume. In placental factors, it will be the remodeling of the spiral arteries and the drugs that are and the drugs or the vascular substances that are excreted.
Yes, proceed.
Now, as we have kept the patient ready, we would shift the patient to the OT table. We would like to secure 2 wide bore IV cannulas. We would like to attach all ASA monitors, that is ECG, non-invasive blood pressure, pulse oximetry, ETCO2, and we would also like to measure the fetal heart rate pre-op and then induce the patient.
Your patient is lying supine. You want to take any precaution?
Yes, ma'am. We would like to give a 10 to 15 degree tilt with the causing the left uterine displacement to avoid aortocaval compression, ma'am.
What are the guidelines for monitoring of the fetal monitoring during non-obstetric surgery?
The guidelines are if the gestational age is less than 20 weeks, we assess for the fetal viability and fetal heart rate. If it is more than between 20 to 24 weeks, pre-operatively and post-operative fetal heart rate monitoring is done. And if it is more than 24 weeks, intraoperative throughout intraoperative monitoring is done if feasible. And if there is no if it is not feasible, like in our condition where it is an abdominal surgery, so before starting the procedure, we go ahead with the fetal heart rate, and then after the procedure, immediately we again assess the fetal heart rate and do tochocardiography.
Fetal heart rate and tochocardiography is important both. Yes.
We would like to pre-oxygenate the patient for 5 to 7 minutes. It is more than the normal patients that we pre-oxygenate because the apnea to desaturation time is reduced in pregnancy because of the decreased FRC. We would like to pre-oxygenate very well so that even during laryngoscopy, there is no hypoxia episodes. We would like to pre-medicate the patient with injection midazolam 0.05 mg per kg IV and anti-sialagogue anticholinergic injection.
You are not preferring diazepam?
Ma'am,
why you are not diazepam or midazolam?
Yes, ma'am. Diazepam has a greater feto-maternal ratio, ma'am. It rapidly crosses over the placenta and it can cause, in the first trimester, it can cause craniofacial abnormalities, cardiac defects, cleft palate, and all of that. And also it can cause floppy infant syndrome, ma'am. That is hypotonia, feeding problems, hypothermia, and respiratory depression. Hence, diazepam is avoided in pregnancy, ma'am. Antisilagogues like injection glycopyrrolate 0.05 mg per kg IV is used. Induction, we would like to induce this patient using rapid.
Why you don't want to use atropine here? Or you are avoiding, right?
Injection atropine also has a feto-maternal ratio of 1. So it crosses the placenta rapidly and it can cause fetal tachycardia, ma'am. Rapid sequence induction is...
rapid sequence induction?
Rapid sequence induction is a method to avoid aspiration where the assistant gives a cricoid pressure of around 10 Newton initially and later increases it to 30 Newton by Sellick's maneuver. This is to push the esophageal, this is to obliterate the esophageal opening to reduce aspiration of the gastric contents. And also in rapid sequence induction, we will not bag mask the patient to prevent regurgitation of the aspirate or the contents. And in rapid sequence induction, we
modified what you are doing.
In modified rapid sequence induction, we will be bag mask ventilating the patient with a PEEP of 2 to 3 centimeters of water, ma'am. And also we will be using a nasogastric tube to aspirate the contents, and then we will induce the patient.
In this rapid sequence induction, you are not providing oxygen. You are not doing a bag mask ventilation. How will you tackle with the apnea period for proper oxygenation?
Ma'am, there are few techniques or methods that we can use for tackling hypoxia because of shortened apneic period in pregnancy. One of them is Thrive. It is transnasal humidified rapid insufflation of ventilatory exchange, ma'am. In which it is a very good apneic method because it uses specialized nasal prongs or nasal cannulae where we can give oxygen 70 liters per minute with a humidifier and we can also use adjustable. We can also adjust the FiO2. So in this also there is a facility to give a PEEP of 5 to 7 centimeters of water. So even during apnea, O2 diffuses from the alveoli into the blood. This is happening in a passive way. Hence, Thrive can also be used.
If not available, if you can't use Thrive or not available, other method is co-oxygenation with
nasal prongs, ma'am. Nasal prongs can be.
Co-oxygenation is always advised when you are using rapid sequence induction.
Yes, ma'am.
Proceed.
Once we have once we have given cricoid pressure, injection propofol is given 2 mg per kg per IV, and then the pressure is increased to 30 newtons, and then we paralyze.
What is your first choice of your intravenous induction agent? Why you
Yes.
are avoiding ketamine?
Ma'am, ketamine is avoided because ketamine causes increased BP, ma'am, increased blood pressure, and also it can cause increased sympathetic stimulation, increased uteric tone, causing decreased it can cause fetal hypoxia, ma'am, because of the increased uteric tone.
Why not pentothal sodium?
Ma'am, thiopentone sodium has an increased feto-maternal ratio, ma'am. It can cross the placenta very freely, and it is highly lipid soluble, and also it is having rapid redistribution also, ma'am. It can cause fetal and maternal sedation.
What about etomidate?
Etomidate is considered, it also crosses the placenta, but main important disadvantage of etomidate is it causes adrenal suppression, ma'am. It causes adrenal suppression, decreased cortisol levels in the mother and the fetus.
Okay. Next.
Injection succinylcholine 2 mg per kg IV is given. A smaller ET
If
tube
your
is
patient has
used, as
received
we have seen.
magnesium sulfate, Stuti, if
Yes,
your
ma'am.
patient has received magnesium sulfate, what about magnesium and succinylcholine or depolarizing muscle relaxant?
Yes, ma'am. If the patient has already received magnesium sulfate can also be used as a pre-treatment before giving succinylcholine to avoid fasciculations and pain caused due to fasciculations. And but when magnesium sulfate has already been given to the patient and we are planning to give succinylcholine, it increases the ED50 of succinylcholine. Hence, a greater dose of succinylcholine will have to be given. With the non-depolarizing muscle relaxants, magnesium sulfate prolongs the paralysis period, ma'am. It prolongs the paralysis action. Hence, a decreased dose of non-depolarizing muscle relaxant will be used, ma'am.
So magnesium sulfate used during second trimester will be for as a tocolysis. If the patient's pressure
Yes.
is normal.
Yes, ma'am.
Proceed. Next.
Attenuation of pressure responses to laryngoscopy has to be done, as we would like to avoid any catecholamine release, any sympathetic stimulation which can cause detrimental effects over the fetus. Injection lignocaine 1.5 mg per kg IV will be given.
So why are you preferring a lesser number of the ET tube? What will be the ideal
as the airway in the mother as the airway in a pregnant mother is edematous and the mucosa is very friable and delicate, so we will use a lesser number ET tube as it can cause bleeding.
Next.
Once induction is done, once intubation is done, we put on the ventilator mode. We prefer volume control ventilation and go with FiO2 to maintain FiO2 of 50 to maintain saturations of more than 95%. We keep FiO2 of 50 to 100% so that we prevent hypoxia and thus there will be more better oxygenation for the fetus also. And the tidal volume is maintained at 6 to 8 ml per kg to prevent barotrauma, and the respiratory rate is maintained at 14 to 18 cycles per minute to maintain the partial pressure of carbon dioxide approximately to 30 mmHg, and keep around 3 to 5 centimeters of water to prevent atelectasis, and airway pressures is kept at less than 30 centimeters of water. This so that it will prevent the venous return. It will inhibit the decreasing of the venous return, and the insufflation pressures are to be maintained in less than 12 mm of Hg so that we can maintain the uterine placental flow, and EtCO2 should be maintained between 32 to 34 mm of Hg, and we have to maintain normocapnia in the pregnancy.
What will be your mode of ventilation?
The mode of ventilation will be volume control ventilation, ma'am, as it provides a stable minute ventilation and also the PaCO2 levels will be monitored.
If there are any pressure changes happening in the intraoperative period, what would you like to do and how will you manage?
Ma'am, first, if there is any changes, ma'am, I would first increase the minute ventilation either by increasing the respiratory rate or the tidal volume, and I'll try to eliminate the CO2. And then if then I'll check for the intra-abdominal pressures. If it is more than 12 mm of Hg, I'll ask the surgeon to reduce the insufflation pressures, and also ensure there is adequate fresh gas flow or proper circuit functioning is there or not, and if there is any no rebreathing. If all these parameters are normal and still there is more of pressures, then I'll go for the pressure control ventilation, as it decreases the compliance. And next, we maintain the anesthesia with oxygen and air with sevoflurane of 0.5 to 1 mg, and with muscle relaxation is maintained with intermittent doses of injection atracurium. And
First choice is sevoflurane and not halothane.
Ma'am, sevoflurane has a rapid induction and emergence, ma'am, and the recovery time is very fast. And other inhalational agents have a delayed recovery time compared to that of sevoflurane.
What about halothane?
Halothane, it readily crosses the placenta, and it also has it increases the uterine relaxation, causing preterm
Delivery is required, it will cause postpartum hemorrhage.
Postpartum hemorrhage, and also it sensitizes the myocardium to the catecholamines, leading to arrhythmias. And also there, because of the physiological changes of the hepatic metabolism in the pregnancy, there is chances of having a halothane hepatitis, which is rare but detrimental. Which is
in some scenario, you have to use halothane when there is a profound uterine relaxation is required.
Yes, ma'am. And when there is, when we need to have manual removal of placenta, so we require uterine relaxation for the prolonged time. So we use halothane at in that place.
In modern anesthesia practice, the role of halothane is for intrauterine manipulations where the excessive uterine relaxation is required. What about other neuromuscular agent, non-depolarizing?
Ma'am, as in atracurium, I prefer atracurium because it is organ independent, as elimination is by Hoffman's elimination, and it is safer in pregnancy due to the changes in the hepatic and the renal physiological changes. And I prefer other neuromuscular agents can be vecuronium, and I avoid giving rocuronium, as there are less studies for the availability of Sugammadex in uses of Sugammadex in pregnancy, as the reversal agent for the rocuronium is Sugammadex.
What about nitrous oxide used during pregnancy? Use of nitrous oxide.
Nitrous oxide use. Yes, ma'am. It has a high affinity to cross the placenta, so there can be a fetal. It affects the fetus, ma'am, and also due to it also increases the vascular resistance, leading to the maternal and affecting the maternal and fetal circulation, and it also has it has an effect on the DNA synthesis, where there will be inhibition of the methionine synthase. So prolonged effect can cause to DNA synthesis abnormalities. Then
methods in hormone analgesia.
Intraoperatively, I prefer to go with IV paracetamol, which is safer in pregnancy. And along with that, before the insertion of the trocars, I inform the surgeon to give port site infiltration with 0.25% of ropivacaine, and also intraperitoneal installation with 0.25% of ropivacaine, around 20 to 30 ml.
Why you are preferring ropivacaine? Why not bupivacaine?
Ropivacaine is more hemodynamically stable compared to that of bupivacaine, and bupivacaine has chances of intraperitoneal absorption is more compared to that of ropivacaine. So it is safer to use ropivacaine.
What monitoring you will do? Maternal monitoring and fetal monitoring intraoperatively.
Intraoperatively, we have to be cautious with the maternal blood pressures, ma'am. We have to avoid hypotension, and also with saturations, we have to avoid drop in saturations, as we have to prevent hypoxemia, and we have to monitor for the EtCO2 pressures. EtCO2 we have to maintain between 30 to 32 mm of Hg, and we have to also look for the if there is persistent hypotension and drop in saturations, even after taking all the precautions, we have to look for the fetal hypoxia, which may be the cause for the maternal this thing. So we have to look for the fetal heart rate also at that time after confirming all these things.
So this is a laparoscopic appendectomy. You are monitoring intra-abdominal pressure. How much of the intra-abdominal pressure you will allow?
We have around 12 to 13 mm of HG. We have to try to keep it. If it is more than that, we have to ask the surgeon to reduce it less than 12 mm of HG. That is a safer.
In your case, according to the guidelines or recommendations, that continuous intraoperative fetal monitoring is possible or no?
No, it is not possible, ma'am, as we are operating in the abdominal area. So I prefer to go with the first. Before the starting of the procedure, I'll monitor the fetal heart rate, and immediately after the end of the procedure, I'll again monitor the fetal heart rate and document it.
What other indirect parameters of fetal reassurance you will monitor?
Ma'am, one is the maternal blood pressures and saturations, ma'am. If there is any drop in this, there can be, we have to predict that there is fetal hypoxemia or fetal distress. Sorry.
Now coming over to the next MCQ. The correct respiratory physiologic change which is associated with the pregnancy is option A, increase in arterial pH, option B, increase in bicarbonate levels, or option C, increase in PaCO2, or is it option D, increase in tidal volume? So kindly everyone type your answers. So what other intraoperative complications are you expecting in your patient?
As we are seeing that it's a laparoscopic appendectomy, there are complications related to laparoscopy, which can be access related, as there can be injury to the uterus, bowel, bladder, or major vessels. And there is also gas related, pneumoperitoneum related complications, that is embolism can occur, hypercarbia causing acidosis can occur, subcutaneous emphysema or pneumothorax can occur, pressure related changes, that is as we know that aortocaval compression can occur even due to the pneumoperitoneum which is insufflated. This can cause decreased venous return, hypotension, decreased uteroplacental perfusion, respiratory complications that can be increased airway pressure and cause hypoxia, cardiovascular changes, that is due to tachycardia and arrhythmias can occur, which can be due to the carbon dioxide, and position related, as we know that in laparoscopy we will have to give Trendelenburg position sometimes, so that time there can be position related nerve injuries and decreased venous return. Pregnancy specific complications that we can foresee are preterm labor, uterine injury, fetal astosis, hypoxia. Post-operatively, the complications that we can predict or anticipate will be shoulder tip pain due to carbon dioxide insufflation and nausea, vomiting, or wound infection.
How will you diagnose gas embolism intraoperatively?
Intraoperatively, gas embolism is diagnosed when there is rapid reduction in blood pressure, increased heart rate, tachycardia, unexplained heart rate, tachycardia, and there is drop in saturation and there is drop in EtCO2 levels.
How much of the age can be allowed before
Considered as
safe?
20 to 25 ml.
5 ml per kg is the 5 ml per kg is detrimental, ma'am, and up till 150 ml will be absorbed. So ideally it is 5 ml per kg. We can consider it as can cause gas embolism.
During embolism, which murmur? Typical murmur.
Millwheel murmur.
What you will do if a patient has developed embolism? What's your action?
How will you manage?
Yes, ma'am. If we are expecting that, or we are thinking that it's an embolism that is occurring, we will immediately give Durant's position. That is, we will give left lateral with a Trendelenburg position, and we will also ask the surgeon to irrigate the surgical field. We would completely cut down air or any nitrous oxide, or we will also cut down the carbon dioxide that is going on in insufflation, and we will give 100% oxygen. And if we have a central venous catheter in place, we will aspirate the air that is present. This is to avoid further migration into the pulmonary arteries.
Your patient has developed hypotension. What is the choice of vasoconstrictor? during pregnancy?
Phenylephrine 25 to 50 microgram, ma'am, it is considered as a safe in pregnancy because ephedrine has detrimental effects that it can cross the fetoplacenta, it can have fetoplacental transfer, and it can cause fetal tachycardia, ma'am.
If you want, you need sometimes use of tocolysis if the patient develops uterine contractions during surgery. What you will do? Which drug you will use?
First, take the opinion of the obstetrician who is there and go with isoxaprine, which is a preferred agent, ma'am, which is a beta-adrenergic agonist, which decreases the calcium influx and reduces the uterine contractions and relaxing the uterus, ma'am.
These are beta-2 stimulants. So
Yes,
what if you give in a higher doses or rapidly, what it does?
Initially, we go with 0.2 to 0.5 milligram per kg IV bolus over 2 minutes, and then we keep a 0.5 to 1 microgram per kg per minute infusion, and we have to watch for the maternal tachycardia and hypotension, and we have to titrate the doses according to the by seeing the contractions.
If sometimes you require emergency cesarean section intraoperatively, what will be your, how will you manage it?
As we already have obstetrician and neonatologist, so we go with laparotomy. We stop the surgery and extend the incision and go with laparotomy, and we have to cut down the air and CO2 insufflation should be removed, and then neonatal resuscitation team will be ready with to resuscitate the baby, and NICU will be kept available. Informed, and we have to,
and you will be ready for
to prevent the postpartum hemorrhage. We have to start with oxygen drip, and oxytocin should be
use uterotonics in adequate doses. Already you have done tocolysis. Now you have to take care of the postpartum hemorrhage by using uterotonics. Okay, next.
So for the reversal, then once we go with the once the patient is having adequate spontaneous ventilation, that is around tidal volume of more than 5 ml.
Monitor the neuromuscular monitoring. How will you give the doses? Neuromuscular monitoring preferably during pregnancy.
Yes, ma'am.
You don't want to give more doses for its benefits to the mother and the fetus.
Yes.
So monitoring of the neuromuscular monitoring is must.
Yes, ma'am. And once the full reversal of the neuromuscular blockade is achieved, that is the train of force ratio is more than 0.9, and the patient is having stable hemodynamics, and the tidal volume is more than 5 ml per kg, and the respiratory rate is less than 30 per minute. I go with the reversal preferably with the neostigmine combined with atropine, neostigmine of 0.0.
So you are using atropine here. Why not glycopyrrolate?
Ma'am, neostigmine has the tendency to, it crosses the placenta, causing fetal bradycardia, ma'am. To compensate that, we go with atropine, which also crosses the placenta, whereas lycopene doesn't cross the placenta. So the effect of the neostigmine cannot be compensated by the
with the use of
it's also we can use atropine. And once the
complications of laparoscopic surgery, you want to add any other complications of laparoscopic surgery?
Complications due to the access related complications, where while inserting the trocar there can be injury to the uterus, bowel, or the other abdominal organs, and gas insufflation related changes where there can be embolism, hypercarbia, acidosis, or there can be subcutaneous emphysema, and the pressure related changes where there is decreased venous return, hypotension, or decreased placental perfusion. Then respiratory changes where because of the insufflation there can be increased airway pressures and further decrease of the functional residual capacity, which may lead to hypoxia. Cardiovascular
precautions will be required while passing the trocar. What precautions the surgeon will take? It's for just your observation, and you will be witness for that. What they will do, where the trocar they will pass?
Initially the trocar open trocars should be used, ma'am, at the subcostal region. The first trocar incision should be at the subcostal region, so to avoid the injury to the uterus. And then we can use optical trocars, which are recently available. And
third option is ultrasound guided trocar insertion.
Ultrasound guided trocar insertion can be used.
Safe. Yes. Next.
After the extubation, the post-operative management, my main goal is for to tackle the pain. So I go with multimodal analgesia. So
Why you
paracetamol.
are worried about maternal pain? How it affects the fetus?
Ma'am, maternal pain it causes increased tachycardia and increase in the surge of the catecholamines, causing again there will be sympathetic stimulation leading to this again affects the fetal hypoxia and distress can lead to distress.
Maternal vasoconstriction, vasoconstriction, decreased placental circulation, and reduced blood flow to the fetus and hypoxia, and also release of catecholamines from the placenta and effects of these maternal catecholamines on the fetus.
So what modalities of analgesia you want to have in post-operative management?
Ma'am, for the post-operation, my preferred one is paracetamol, ma'am, which is safer in pregnancy, and I go with regional techniques, which are again safer. These are some of the blocks which I prefer after the surgery. The transverse abdominal plane block with 0.25% of bupivacaine with 20 ml on each side, and rectus sheath block, port side infiltration before the surgery, and quadratus lumborum block can also be given, and intraperitoneal infiltration either before the surgery or post-surgery before closing can be given. And if at all, if there is any chance of securing epidural catheter, we can give epidural analgesia if the catheter is placed to tackle the post-operative.
Or in the post-operative,
if required. And what are the effects of opioids on fetus and mother?
I'm sorry, ma'am, question. Opioids.
What opioids you want to prefer in the post-operative pain management if the pain is not subsiding
with the
use of your NSAIDs, Abosave, or your
preferred opioid will be fentanyl, ma'am, as it is short acting and it has a less affinity to cross the placenta, and rapid recovery is there, ma'am. And we avoid morphine as it causes neonatal depression and also the neonatal depression and hypoxemia can occur, and if remifentanil and sufentanil, as they are short acting and require repeated doses, and repeated doses is not safe in pregnancy, so we avoid these drugs.
NSAIDs?
Ma'am, NSAIDs are avoided, ma'am, as it is can cause premature ductus closure.
Premature closure of patent
ductus artery.
Okay. Coming on to our last MCQ for today's class. What are the adverse effects of inhaled beta-tocolytic therapy for preterm labor to the mother? Include all of the following except hypoglycemia, pulmonary edema, tachycardia, or ventricular arrhythmias. So now you have successfully managed your case. You have extubated. You have even covered the post-operative pain management also. You have done successfully. So in short, can you give me a list of the FDA approval given to the anesthetic drugs and which categories it has been given, and what do you mean by the different categories of the FDA?
FDA has given us a list of commonly used anesthetic drugs, ma'am. The categories are as follows. If it is A category, it means that there is no fetal risk present in the first trimester or later. And if it is B category, it is said that there is no risk in animals, no studies in pregnant females. If there is C category, it says that there are studies with animal risks or harm present. If in D category, there is high risk in humans, but the benefits outweigh the risks, so it can be used. And X category is completely teratogenic, has to be avoided. So lignocaine or local anesthetics, bupivacaine comes under category C, lignocaine comes under category B, succinylcholine, vecuronium, rocuronium comes under category C, thiopentone sodium comes under category C, propofol B, and fentanyl comes in small doses, as we have seen, comes in category B, but in higher doses can come in category C. Remifentanil comes in category C.
if your case is posted for open appendectomy, how will you plan? Or what is your choice of anesthesia?
Ma'am, if the case is posted for open appendicectomy, we will prefer regional anesthesia, ma'am. Regional anesthesia, we will have to, as we have seen, we have to avoid aortocable compression, maintain normotension, maintain the blood pressure, maintain the map
So what
of the
problems you will face with the regional anesthesia, that is the subarachnoid block during pregnancy, and what precautions you have to take?
Ma'am, basically, there will be difficulty in positioning of the mother, ma'am. There will be increased lumbar lordosis also. And when we are positioning, we will have to give a 10 to 15, when we are placing the patient, we'll have to give a 10 to 15 degree tilt to cause leftward uterine displacement to prevent aortocable compression, or a wedge can be placed of 15 centimeters, ma'am, to maintain the blood pressure.
What
And also-
about the volume of the drug during pregnancy as compared to non-pregnant female?
As we have seen that the epidural veins are engorged, there is a decrease in the space of the subarachnoid space and the epidural space. We will have to give a lesser dose of drug, ma'am, as there is increased sensitivity to local anesthetics also, and there is increased CSF pressure. We will have to give lesser dosage of drug. Drug dosage of local anesthetics has to be reduced to 20 to 25%.
And as there is increased sensitivity, ma'am, so there is more chances of regional anesthesia drugs causing hypotension. So we have to make sure maintain the adequate blood pressures by giving adequate fluids and maintain with vasopressors.
Sir, thank you. Shall we go for the answers? Answers
Yes.
to all MCQs?
Yes, please. Yes, please. Yes. Thank you all for first of all the office bearers of ISA national online classes, Madam Madhuri Madam and Sir, for giving us opportunity to present here along with our postgraduates from MR Medical College Kalburgi, and all the participants who are attending the class. Thank you very much.
So now going ahead with the MCQ answer keys. For the first MCQ, the question was, by the third trimester of pregnancy, the cardiac output increases to nearly 50% due to which of the following alterations? So the answer is option D. There is an increase in stroke volume, so leading to increase in the heart rate. And for the next MCQ, option D. During pregnancy, the disproportionate increase in plasma volume versus erythrocyte volume accounts for relative anemia of pregnancy. And in the third MCQ, the P50 for maternal hemoglobin, it increases due to elevated levels of the 2,3-diphosphoglycerate. Then coming over to the fourth MCQ, when providing general anesthesia during pregnancy, the MAC is decreased. MAC progressively decreases during pregnancy, and at term it is decreased as much as 40%. And coming over to the fifth question, the correct respiratory physiologic change associated with pregnancy is there is an increase in tidal volume. Rest other things are taken care. Even if there is an increase in arterial pressure also, that is taken care with the increase in the minute ventilation and the tidal volume. And when there is an increase in bicarbonate, it will again lead to the increase in the creatinine clearance. And then coming over to the next MCQ, the adverse effects of inhaled beta-tocolytic therapy for preterm labor to mother include all of the following except for the hypoglycemia. The other conditions are seen in this thing.
As already we discussed, these are the beta-2 stimulants which will cause peripheral vasodilatation and hypotension, tachycardia. It will increase the uptake of potassium in the cell and reducing the potassium level, causing hypokalemia, which will increase the chances of arrhythmias with the use of this, and it will cause hyperglycemia because of beta-2 stimulation. So the correct answer is hypoglycemia. Thank you, ma'am. Thank you all.
Yeah.
Screen
thank you,
coordinators,
team.
just see what questions.
I don't think so. There are any questions. Majority of them have been answered, I think.
Yes, sir. There are no particular questions right now.
So I think a wonderful job done by the team. So it's our time to felicitate the team also. Yeah, screen is visible.
Yes, sir.
Yeah. So thanks to the team, and we are happy to felicitate Dr. Mohammad Yahya, who's the professor and head of the Mahadevappa Rampure Medical College. And thank you, sir, for preparing your team for this presentation. Then
Thank you, sir.
Hear
Dr.
you,
Nanda
sir.
Nandyal, madam. Thank you very much, ma'am. You being the moderator for
We are
this
not
session.
able to hear, sir.
Just wait, ma'am. Now you are able to hear?
Now able to hear.
Okay, I will. So, Nanda madam, thank you very much for being the moderator of this class. So here's a gesture from the national headquarters as a mark of felicitation. Then Dr. Rupal Konde, madam, thank you very much for preparing the PGs also to present such a wonderful class and being the moderator of this class. And Duname Stuti, yourself, as well as Dr. Sai Vijayshiri, thank you to both of you. You did a wonderful job. You were confident and you prepared your class very well, and we are thankful to you.
Thank
Thank
you,
you,
sir.
sir. Thank you for giving the platform.
And Ankita Saini, yourself, and Gauri, both. So thanks for being such a good screen coordinators. And you have done a wonderful job as a screen coordinators, and we will continue this class further now. Any question is there? We have got 3-4 minutes left. You can go for any question and answers if somebody wants to ask.
Sir, someone has typed, can you please repeat about analgesia post-operative?
So who is going to take that, PGs or the moderators?
Post-operative analgesia, our first choice will be paracetamol, which is safer in pregnancy. And then
The slide, you can put the slide.
yes, ma'am. First is paracetamol, which is safer in pregnancy, and we go with the regional techniques, that is transverse abdominal spleen block, rectus sheath block, and before the starting of the procedure, we can give post-site local infiltration with 0.25% ropivacaine, and after that, intraperitoneal infiltration can be done. Installation can be done with 0.25% ropivacaine, 20 to 30 ml, and other blocks post-operatively which can be given is quadratus lumborum block and rectus sheath block. If there is any, if epidural is secured and if the catheter is there, then we go with epidural analgesia.
So we covered the IV analgesic part, and along with that, any facial plane blocks that can be given. And it will be helpful in laparoscopic surgeries. The main thing is like as we are preferring laparoscopic over laparotomy because of the less pain and more mobility, easy mobility and easy early recovery. So we can still go ahead with the facial plane blocks. Preference more towards the IV analgesics along with the paracetamol and low doses and safer doses of the opioids like fentanyl. And along with that, we can, if we are doing port insertion, local anesthetic given at the port insertion, that will also help in taking care of the pain in the post-operative period. and even the intraperitoneal installation, which is safer, and many articles have been published on the same thing. So that is also considered as another safe option in pregnancy.
Kindly adds a note on thromboprophylaxis during pregnancy. You would like to add anything?
Yes, ma'am. As we know that pregnancy is a hypercoagulable state due to increased coagulation factors. In pregnancy, if the patient is posted for non-obstetric surgeries, we would like to go with prophylaxis to avoid DVT. That is, we can use pneumatic devices, compression stockings. We can also give injection low molecular weight heparin, ma'am. It can be given 40 mg subcutaneous OD. If the patient is high risk, obese, we can also give 40 mg subcutaneous PD, ma'am.
And you will
Early
encourage for the
mobilization,
early
early
mobilization.
ambulation. Ma'am. Yes.
Yes, ma'am. Ma'am, Madhuri, ma'am.
Yeah. Thank you for a very wonderful class. I think you have covered almost everything regarding non-obstetric surgery in an obstetric patient. Just like to add that the preoperative counseling of the patient is also very, very important, because the patient will be very, very anxious. Okay, this for the PGs. So the patient will be very anxious. Just imagine being pregnant and having to undergo this kind of surgery. It's very unfortunate. So you have to counsel the patient, because she'll be very worried about the fetus, the loss of the fetus. So reassurance, preoperative reassurance, counseling of the patient is also very important, because they will be worried about teratogenicity. They will have heard everywhere that so many of these drugs can prove teratogenic and something will happen to the fetus. And you have to also educate the patient about preterm labor. It is likely that she may go into preterm labor post-op. So you have to educate her about that. And also you have to teach her that she has to be sleeping in the about left uterine displacement and in the left lateral position. That is important post-op. And most important, to top it all, you have to document this in the patient records, that the risk has been discussed with the patient and has been informed to the patient, because tomorrow you should not land in medical legal litigations and problems. So spend some time talking to the patient and the relatives that these are the possible problems that can arise after the anesthesia and surgery. Okay, so risk counseling, reassurance, and documentation, all these are very important.
The parameters we have to preoperative and postoperative documentation, and keeping the records for longer time is also very important in pregnant patient.
Yeah. Yes. Anything else you want to add, Dr. Nishant?
No, ma'am, that the topic has been very well covered. I mean, there's not much that you can add. Very comprehensive and very nicely done.
Thank you, sir.
Thank you, sir.
Thank you so much, sir.
So we come to the end of this class and meet you the next Monday actually. And till then, I think it's good night and goodbye. And we end by saying long live ISA.
Long live ISA.
Long live.